recorded, and just note at the end there will be a questionnaire to fill out as we go through. The session at the end will also be available for others to view. So I'll hand over now to Merlin Thomas and to start the presentation.
Well, good evening, Western Australia. Thank you for coming out this evening and for this, what I hope will be an exciting seminar on SGLT-2 inhibitors and their potential role in diabetes management. Some of you will be familiar with SGLT-2s, but I can tell you over the next 12, probably to next 24 months, you're going to become increasingly familiar with them because they have really revolutionized both second-line and other kinds of therapy for the management of diabetes. Because really for the first time we have an insulin-independent pathway for lowering glucose levels. And many patients are now going, I want some of this because of its additive effects on glycemic control as well as weight control, blood pressure, and other parameters. So what we're going to do tonight is have a quick overview of just how SGLT2 inhibitors work, and then we're going to go through some cases to try and look at some of the challenges in starting an SGLT2 inhibitor, some of the challenges in using them, and in particular in different contexts in addition to insulin, which will be the new indication as of the 1st of April. So we can have the next slide, please. Here we go. Yep. So the first thing that we're going to do is have a quick look at about how does an SGLT2 inhibitor actually work to lower glucose levels. Next slide, please. So although you might think of diabetes as intrinsically a disease of the pancreas, for millennia, in fact, diabetes was considered a disease of the kidney. In fact, diabetes mellitus, the siphon of honey, was originally described as the wasting of flesh and limbs into urine because the kidney was in fact killing patients. It's only the last 100 years that it's been a disease of the pancreas. It turns out the kidney has a key role in the management and the regulation of glucose levels. So under normal circumstances, let's say your sugar levels are about 5 to 6 millimoles per litre, about 180 grams of glucose are filtered into the primary urine through the glomeruli every day. Now, 99.99% of that glucose is then reabsorbed by the SGLT-dependent pathways in the proximal tubule. So that means that what ends up in the urine is, less than 100 milligrams of the original 180 grams of glucose. And this is the reason that urine is reported to not taste very sweet, because there is no glucose in it. Next slide. In diabetes, of course, because sugar levels are approximately twice normal, the filtered load in the primary urine is twice normal. Let's say about 360 grams every day. And that's beyond the capacity of the kidney to reabsorb it. And so it spills over into the urine. Although the kidney tries very hard to retain that extra sugar, it knows that so much sugar is going through. And in fact, it upregulates pathways to retain that sugar, even more than in a normal situation. Next slide, please. This is illustrated in this slide, where if you imagine the glucose level on the bottom axis going up and up and up, at some point under a normal circumstance in blue, glucose begins to spill over into the urine. Whereas in diabetes in yellow, it doesn't occur until a much higher level, so that the capacity is increased and the threshold is increased. So that you might imagine a patient with diabetes who has already got high sugar levels, their kidneys are pouring back into their body an extra 60 grams of glucose every single day, and therefore the pancreas needs to make more insulin to deal with this. Next slide, please. And this is where SGLT-2 inhibition comes in. An SGLT-2 inhibitor reduces the reabsorption of glucose through that proximal pathway by about 30%, meaning the maximal capacity is reduced by a small amount, but a significant amount, so that on average, when there is 360 grams filtered, an extra 60 grams will end up in the urine. And that means better glucose control. Next slide. And this can really be illustrated both to you as educators and to your patients by using a beer glass, which is a very popular way of explaining diabetes. So imagine in a healthy situation, your glass is half full, and even if you should pour in a little bit more by having an extra sweet drink or dessert, you'll never exceed the capacity to hold glucose in the body, and so it will never spill over, you'll never get glycosuria. In diabetes, the capacity increases to try and pull extra glucose back into the body. But if sugar levels should rise, probably above somewhere around about 13 millimoles per litre, glucose then spills over into the urine, and you get the classic symptoms of glycosuria with weight loss, polyuria, frequency, etc. Dry mouth, dry eyes, all due to glycosuria. What SGLT-2 inhibitors do is simply make the glass smaller. That's all they do. They don't affect the pancreas, the liver, the other things. They just tell the kidney to reduce its capacity to hold glucose in. So should glucose levels rise to the same extent under normal circumstances, there is much greater spillover. And that's why you get more glycosuria at the same level of glucose. Next slide, please. And this is perhaps illustrated best by this lovely study by Ralph DeFronzo, where he showed that if you took a normal individual with diabetes, shown in the blue line, and gradually increased their glucose level, what would happen is that small amounts of glucose and then increasingly large amounts of glucose would be filtered out. But for the same glucose level in someone treated with an SGLT-2 inhibitor like dapagliflozin, you had substantially more glucose ending up. So, for example, if your sugar levels were somewhere between 5 and 10 millimoles per litre, in other words, what most of our diabetic patients are, under normal circumstances you don't have much glucose in the urine, which is where the red line is. But in a patient on an SGLT-2 inhibitor, around about a quarter of all that glucose that is filtered, a quarter of that 200 grams or so, ends up now in the urine, which is where you get 50 to 60 grams a day. Whereas if you are running sugar levels on average 15 millimoles per litre, under normal circumstances maybe 5 to 10% would spill over into the urine. But with this agent, now 60% of that load of 500 grams, or enormous amounts, 250 grams, will now spill into the urine. So the worse your sugar levels, the much greater effect that this drug has. Next slide, please. So when you look at trials of this agent, it's very clear that SGLT-2 inhibitors are able to lower the glucose levels. And the A1C lowers by, on average, around about 0.6, 0.7, although greater reductions are seen with patients with much poorer control. You'll see here the only one trial in which the drug did not work was in patients with chronic kidney disease, and whom you'll hear later, the drug is contraindicated because simply it doesn't work. Next slide, please. The other advantage of SGLT-2 inhibitors is that by spilling over glucose into the urine, you lose energy or calories from the body, and you lose the equivalent of 300 kilocalories a day. Of course, you lose much more at the beginning, but on average, you'd lose 300 kilocalories a day, and that's not insubstantial. That's about the same amount of calories in a Snickers bar, or 2 cans of classic Coke, or walking the dog for an hour. Instead, all you needed to do was walk to the toilet and remove those calories from your system. The same negative calorie balance with exercise achieved just by urinating. Next slide, please. And this means that agents like dapagliflozin can significantly reduce weight. In this study, where patients were on metformin and a second-line agent was added, either a sulfonylurea, which caused weight gain, or dapagliflozin, an SGLT-2 inhibitor, which caused weight loss, you can see how nicely the weight came down. So within 6 months, they'd lost 3.5 to 4 kilos. And that weight stayed off for 4 years. Next slide, please. But the real advantage of that weight loss is not that patients are just lighter, but in fact, by removing glucose from their system, they actually lose fat. And the reason for this is quite simple. When glucose is removed from the body goes, I need glucose for my brain. I better preserve it because it's going out of the system. And instead I'll burn an alternative energy substrate, like fat. So lipolysis goes up with this agent, kind of like exercise. You exercise, your fat goes away because your muscles are using glucose to make glycogen. In the same way here, you are actually burning fat, and both visceral and subcutaneous fat goes away with this agent. Next slide, please. So in our first case, we're going to look at how you start this agent. What challenges might exist when you begin this kind of therapy. So if you imagine that we know this agent lowers glucose, has some positive effects on weight and other kind of things, what might be the challenges when using it, or the restrictions, or the encumbrances? Next slide, please. So let me introduce you to Graham. Graham's a classic Australian. He's 50 years old. He's married with 3 children and works as a taxi driver. His blood pressure is not too bad now that he's on medication. His BMI is average for an Australian of 50 years. In other words, he's obese. He is a non-smoker and his diet is not particularly optimal as a taxi driver. He's had diabetes for about 18 months. He's got high blood pressure and not so good lipids, although they're pretty good now that he's on rosuvastatin. However, his A1C at 7.9 is not adequately controlled. And given his age and other risk factors, it's really worthwhile saying he needs to get better glycemic control. Next slide, please. So, of course, there are a number of different challenges in this gentleman. Obviously, you want to improve glycemic control, but there are also the counter-bearing arguments of getting his cardiovascular risk down, reducing his weight, using a drug that's sustainable, it doesn't cause hypoglycemia, that is of not too much cost, but most important that he'll take because it's tolerable. Next slide. So the first sort of question that we would have, and indeed the most important priority in managing diabetes, he's on metformin. The question is, if I start an SGLT-2 inhibitor, will he actually tolerate it? What will be the reasons that he doesn't want to take it, and what are the reasons that he might stop taking it? And this is the point at which an educator can come in and say, let's warn you about these things, let's prepare you about these things, and let's see what we can do to minimize their risk and the likelihood that they will interfere with your compliance and or its effectiveness. So to begin with, we ask the question, how well will Graham tolerate an SGLT-2 inhibitor? And I'll hand it over to our panel, which is Gary Kilov and Nicole Frayne.
Nicole, do you want to take this one?
Okay, all right. Well, hopefully everyone can hear me a bit clearer tonight, but I guess from this perspective, I think the priority for Gary as an income earner and taxi driver for his family is keeping that and not influencing his ability to drive. So we've already eliminated that hypos aren't a risk, but what else might influence his ability to continue driving? And so really its effect on what it's doing to his urine output and possibly any risk of infection. So if he increases his urine output, is that going to influence how he can manage his driving? Is it a long-term effect or is it short-term? So that's what we need to look at. Gary?
Yeah, and Nicole, I absolutely agree. I think Merlin covered off very well on the amount of glucose that's excreted, but I don't think it was mentioned that as a result of the glucose being dumped, you're also getting an osmotic diuresis. And the question is how much more urine is going to be produced. Generally speaking, the amount is not that much. It's going to be about 300 to 400 ml, so roughly the equivalent of a can of soft drink. Now, in most instances, that would be one full bladder, so an extra voiding a day. But I have the experience of having a patient very, very similar to this, in fact, who was a taxi driver, but that increase in amount of urine production actually translated into polyuria. In other words, quite significant increased frequency. And the problem with him was that there was some underlying prostatic hypertrophy, and I guess the SGLT-2 really unmasked that underlying condition in this gentleman. So really tipped him, I guess, from being asymptomatic or mildly symptomatic to somebody who became quite significantly symptomatic. And as he quite reasonably explained, that as a taxi driver, you can't just stop on the side of the road and respond to nature's call. So in that instance, that was not the ideal choice for him. And of course, if tolerability is a problem, then so becomes compliance. The other issues I think you mentioned in terms of risk of infection. So balanitis is potentially a problem, and I guess that's a question we'd want to ask if men have had problems with manilial infections. Other issues around tolerability, I think, would not be too much of a problem with this gentleman if he was able to hold the urine and not have the frequency problem.
Well, thanks, Gary. Can we go to the next slide, please? The greatest concern, as both the panelists mentioned, the greatest concern about these agents is the fact that it causes an increase in urine output. Anything that puts glucose into the urine will make more urine flow. And it is proportional to the glycosuria. So that if you give it to an individual who has got terrible glycemic control, their A1Cs are 10, 12%, they've got sugar levels well into the 15, they will pee a lot of glucose out because their threshold is substantially reduced. And that, of course, means that they get good glycemic control. But often at initiation, that means they have quite an extensive diuresis. Now, of course, you might say, oh, that's a bad thing, but sometimes it turns out to be a really good thing, because unlike a DPP-4 inhibitor or other kinds of drugs, where you don't feel any different, when you take this and you've got poor control, within an hour or two of taking it, you feel that it's working. You pass more urine, your stream is increased. And we've had really good success with this agent, particularly with businessmen who would otherwise have to take sulfonylurea and eat food to avoid hypoglycemia. They switch over to this thing, and suddenly they know the day they took it because their urine flow is increased. They are and the strength of that flow is increased, so they feel healthier. But the other thing is that there's a biofeedback element, so they know that it works. But although that there's an increased diuresis, particularly initially, usually that settles down. And on average, as Gary said, that most individuals on this chronically will only pass maybe 300, 400 mils extra every day. So that's peeing once more extra every day. And you might say that's terrible, but surprisingly it's extremely well tolerated. And in the trials that have been done, very few individuals end up complaining of polyuria or symptoms, whatever. Next slide. But of course, as Gary said, that there are some individuals in whom making them pass more urine is not ideal. Obviously, you'd recommend you take this drug in the morning to allow you to pee through the day rather than at night. But you wouldn't want to use it if someone had bladder problems or pelvic floor dysfunction. someone who's prone to stress or urge incontinence, to truth or instability or urinary retention. And as Gary said, prostatism, a lot of people don't know they've got prostatism, but if you make them pee more, then you might unmask it. And so it's really important to discuss these things with your clients, discuss the issues of how your bladder is going, and then seeing what can be done to limit any risks. In general, you use this agent in younger, fitter, healthier bladders and patients, whereas in the majority of our older patients, causing them to pass more urine may not necessarily be the right thing to do. Next slide, please. The other issues that people are concerned about is that if you pass that much urine, you'll get dry. And of course, being dry, one of the first symptoms is constipation. And you'll see the red bars, they're not particularly higher than the blue bars, it's the placebo. So it really doesn't cause constipation, even though you might think it dries people out. Next slide. But in men, as Gary mentioned, there is a significant issue of genital candidiasis. And so that particularly uncircumcised men who are diabetic, obese, not looking after genital hygiene, they're quite prone to balanitis, redness in and around the foreskin. And of course, if it becomes red and swollen, it can become compressive, and rarely it needs a circumcision to treat. So what you have to remind adult males that are on this agent is that you need to look after your genital hygiene. And if you have problems, then clearly, and particularly if it goes red, you need to get it treated. It's very simple to do, to treat, in terms of buying a cream from a chemist, but you need to be proactive in terms of planning. And in these trials, you can see that somewhere between 2 and 5% of patients in these trials required some form of therapy for a genital infection. Next slide, please. So here's Graham again. And the second question, of course, was referred to before, is the risk of hypoglycemia. Clearly you want to lower his A1C down from 7.9, and clearly you want an agent that's highly tolerable. But really a top priority in a taxi driver for your choice of next therapy is going to be an agent that does not cause hypoglycemia. So how about this agent? What about driving on an SGLT-2 inhibitor, apart from having to stop to pee? What do you think about hypoglycemia with this agent, Gary and Nicole?
Yeah, I think one of the beauties of this agent, and some of the other new agents that we have, is that there's no significant hypoglycemic risk, particularly if added to another agent such as metformin that doesn't cause hypoglycemia. And the SGLT2 works, in fact, most effectively the higher the glucose is. So it almost kind of self-modulates its effectiveness according to the extent of hypoglycemia. And for somebody who's a commercial taxi driver, it's just a no-brainer that he cannot afford to have any hypos. This would, if he were to have a severe hypoglycemic episode, this would have potentially, significant consequences in terms of an accident. But even if there were no accident and or no injuries, this would affect his livelihood. He'd have to come off the road, and it would just be a catastrophe for him. So, in this instance, it would be this is a great choice. SGLT2s can increase the risk of hypoglycemia when they're added to other agents that can cause hypoglycemia, such as insulin and sulfonylureas, but his risk here is very low.
And I think it's just thinking about its mode of action, so it's really quite separate from that pancreas and stimulating it to produce insulin, so therefore that hypo risk is going to not be there. The other comment I just wanted to make, Merlin, when we're comparing CANA, DAPA and EPA, we've only got DAPA here, haven't we, out of the SGLT2s?
Yes and no. In terms of the SGLT2 inhibitors, currently until later this year, CANA is still here, but they have withdrawn from the market. And very soon, within the next month or so, I think we'll see a marketing push for empagliflozin, which has got a presence that's coming. So I think that it's a moving feast, and there may be more coming. So know that it's not just dapagliflozin, although that clearly is the front runner because A, it was the first, and B, it is in terms of practical terms very easy to use because it's only a single dose. So can we have the next slide, please? So the real advantage of an agent like dapagliflozin for patients such as this gentleman is this low risk of hypoglycemia, as Gary referred to. So if you imagine comparing it to, let's say, a sulfonylurea, where over a 52-week period, we're looking at 40% of individuals, 40% have a hypo of some kind. And the other ones are doing some things to try and avoid it, including eating more or exercising less, which are undesirable. By comparison, an SGLT-2 inhibitor can actually achieve comparable glycemic control over the same time period, and yet has little or no risk of hypoglycemia. Next slide, please. And just go 2 forward for me, please, because that animation is bugging everyone. Keep going. 1 more. Great, stop there. So if you look at what happens to the threshold for glucose spilling over, under normal circumstances, in the red line, let's say there, you don't get glucose spilling over until about 13 millimoles per litre. Whereas with dapagliflozin, it starts spilling over at 5 and then increases significantly from there. But what we'll also see is that when sugar levels are in the normal range, very little spills over. In fact, by the time you get below about 5 millimoles per litre, virtually no glucose spills over to the urine. So if you can't lose glucose, you don't cause hypoglycemia. Same with the beer glass. If you don't overfill it, you don't end up any spillage. And that's essentially what happens in diabetes, where if your capacity is so high, even if you reduce the capacity, if the glucose levels are low, they will never spill over. And that's why these agents simply don't cause hypoglycemia, unless you combine them with an agent that releases insulin at the wrong times or in the wrong amount. Next slide, please. So the other really important question for this guy is not only tolerability, not only hypoglycemia, but he's 50 years old. And your plan for his treatment is actually for him to be treated for his diabetes for at least another 20 years or so. And what you want from that therapy is a therapy that will be his best friend for the next however many years, not one that works for a short time and then leaves him. And that's really the greatest challenge of therapy now, is that we are managing diabetes not for a few weeks or a few months of glycemic control, but we want decades out of whatever we can do. We're in it for the long haul. And sustainability now is a very key priority of managing these younger individuals with diabetes. So again, to the panelists, how well do you think an SGLT-2 inhibitor will keep working for a guy like a 50-year-old Graham? Over to the panel.
I think given its unique mode of action, particularly being beta cell independent, the sustainability of these agents is quite impressive. And certainly in the trials, we've seen that the amount of glucose that's excreted on a daily basis remains quite consistent, several years later. And as long as the kidneys continue to filter adequately, that sustainability will remain.
I agree. I think it's an independent pathway, so we know that the pancreatic decline is progressive, so that this is a completely unique pathway, so we've got an option there of adding it in, not necessarily early, but at any stage in this diabetes.
Thank you. Next slide, please. As mentioned already, it's very clear that some agents do lose their efficacy over time. And this is classically illustrated by these trials using sulfonylureas, which have their maximal effect at 6 months of therapy, but then rapidly lose their ability. And by the time you get to 2 or 3 years, are back to essentially where you started before. And this is often called the Nike effect, by the way that it goes down and then very quickly comes up. Now, this is thought to be because drugs like sulfonylureas work in the pancreas, and that by making them make insulin, not when you need it, but all of the time, the pancreas becomes exhausted and therefore loses some of its function. Whether this is pancreatic exhaustion or beta cell loss, or whether this is just patients getting tired of the hypos and the weight gain, is not clear, but you do lose efficacy with these agents quite significantly. So when you're considering, for example, a 50-year-old, you want an agent that works, not only now, but you want something that's going to keep working for a long period of time. Next slide, please. And so when you see a trial of a sulfonylurea going head-to-head with an SGLT-2 inhibitor, dapagliflozin, again you see the classic Nike effect with the sulfonylurea, good initial control but quickly losing it, so that by 1 year they're absolutely equivalent. By comparison, whatever you got initially with the dapagliflozin really is sustained over a period of time, and this trial was over 4 years. And that's simply because the dapagliflozin doesn't work in the pancreas, doesn't work in the liver, doesn't work in metabolism. It just works by making your beer glass smaller so your beer spills out. Essentially lowers the threshold. And by working on that pathway, completely independent of insulin, it provides a unique mechanism of action which cannot get exhausted. If sugar levels rise, if you pour it in the top, it'll spill out if you pour in too much, regardless of whether it's now or in 4 years' time or in 10 years' time. There's nothing to exhaust. If glucose levels rise, it'll be there to spill things over. Next slide. And the real advantage, as was alluded to by Nicole, is that these agents work through an insulin-independent pathway. So very much similar to what you see with exercise. You say, patients, please do some more exercise, because we know physical activity burns glycogen in muscle, and then the muscle then takes up glucose through an insulin-independent pathway. By taking up that glucose, the pancreas goes, well, that's great. The glucose is not there. I don't need to make insulin to keep those glucose levels under control. I can sit back, I can relax, I can do less work. From the pancreas's point of view, an exercising muscle that takes up glucose, or a kidney treated with an SGLT-2 inhibitor that loses glucose, is practically the same. There's less glucose there, then there's less work for a pancreas to do. And of course, if you have a pancreas that really isn't up to much work, as is the case in many of our patients with type 2 diabetes, then of course there is a real advantage in reducing its workload and in terms of preserving its function. Next slide. The other really important thing about Graham, of course, is cardiovascular risk. You can have a drug that lowers the A1C, is quite tolerable, doesn't cause hypos, but if it modifies cardiovascular risk, as we found with drugs like rosiglitazone, then it shouldn't be part of routine medical practice, certainly for patients with diabetes. And as a result, cardiovascular risk is a key focus now of all diabetes drugs, because in fact you're lowering glucose to keep those cardiovascular events away, because indeed 75% of people like Graham are going to die of a cardiovascular event, and our job as practitioners is to try and reduce that risk. So again, to the panel, what do you think an SGLT-2 inhibitor might do to protect his heart? Over to the panel.
Yeah, I think, as you mentioned, cardiovascular risk is so central to the management of diabetes, and it's the issue of managing cardiovascular risk but also not adding to cardiovascular risk with the agents that we choose to treat the hypoglycemia. And since the rosiglitazone, I guess, debacle, if you like, highlighted some of the concerns around the cardiovascular safety, it's now mandated that these agents go through thorough cardiovascular assessment in terms of their safety. So I think we are still waiting on the major outcome trials, but if we look at the at least the surrogates that are affected by SGLT-2 inhibitors, they do seem to be somewhat reassuring. The osmotic diuresis and natriuresis that occurs as part of the mechanism of action results in a drop in blood pressure, and in a population where blood pressure is often difficult to control as part of the whole metabolic syndrome, having an agent that reduces blood pressure is quite handy. Weight loss is beneficial in terms of reducing cardiovascular risk, and as you mentioned, Merlin, that weight loss is not just fluid due to the osmotic diuresis, but in fact is I think 1/3 of it is fat, and much of that fat is in fact visceral fat, which is the fat that we're concerned about as far as cardiovascular risk is concerned. There's also an interesting effect on the lipid profile, which is a little bit mixed in that we do see a slight increase in LDL, so the particles that are atherogenic, we don't like that, but we also see an increase in HDL as well, which is protective, and a decrease in triglycerides. So overall, the cardiovascular effect of these agents is likely to be either neutral or possibly even positive. And we do certainly have some data from phase 3 trials and some post-marketing information suggesting that these agents may have some benefit. But of course we do need to wait for the outcomes of the prospective randomized trials.
And I guess that's what I'm waiting to hear. I know when they were first marketed we didn't have that trial information, so when would we expect to see some results and how are they looking?
Next slide, please. Well, as Gary mentioned, it's very clear that not only are you losing glucose into your urine, you're also losing salt out into your urine, much in the same way and the same amount that you do with, let's say, a thiazide diuretic. And so as a result, you get a blood pressure reduction. And in these trials, they show a blood pressure reduction of around about 4 to 5 millimeters of mercury in systolic blood pressure, with a baseline blood pressure of around about 130. So you've gone from 130 to 125. Of course, if you start with a higher blood pressure, or your blood pressure is particularly volume sensitive, like you're on a RAS blocker, then the blood pressure reduction is much greater. Remembering this drug is not indicated as a blood pressure lowering agent, because of course it wouldn't work outside of diabetes, but it does have beneficial effects on blood pressure. Next slide. And this is shown here, the blue line being the SGLT-2 inhibitor, the red line being a sulfonylurea, seeing a major difference in blood pressure around about 4 millimeters of mercury. And that's not inconsiderable. Next slide, please. But as Gary mentioned also, there is this paradoxical effect on lipids, with the LDL cholesterol rising by about 3%, but at the same time the HDL cholesterol also rises and the triglyceride falls. What this means to cardiovascular risk still is unclear. Which is more important, a little bit of increase in LDL, or a 4-kilogram weight loss, or a 4 millimeter reduction in blood pressure? And that really is the interesting question of really the next few years that needs to be answered. Next slide. We certainly have data from all of the trials that have been done already. So while rosiglitazone clearly was associated with increased risk of problems in its pre-marketing trials, as shown by Steve Nissen, when you look at all of the data of these trials put together of some nearly 8,000 patients, there seems to be no adverse safety signal. There's no increased risk of heart attacks or stroke or other kinds of things like that. But the number of events are small. For example, you're only looking at 66 events overall with myocardial infarction. But it is very exciting to think that, for example, MI, when you look on average, you're reduced by 43%. When you look at heart failure, from hospitalization for heart failure, it's reduced by nearly 2/3. Now, again, these numbers are too small to make any judgment on, but it's really exciting to think that there might be some benefits here that remain to be proven. Next slide. And it won't take long. There are some absolutely monster trials ongoing to try and determine whether a drug that causes weight loss, improvements in glycemic control, and drops in blood pressure might also be protective for those things which are important, like the heart and stroke. And indeed, the DECLARE TIMI with dapagliflozin probably is about 3-4 years away still, is going to follow very closely a large group of individuals. There'll be other trials with empagliflozin and cana, which will come in much earlier, probably in the next year or so, to give us a good idea about cardiovascular risk in these settings. So really exciting times to watch this space. Next slide, please. So the next case that we're going to talk about is SGLT-2 in older patients. Of course, we know now that around about the average age of a diabetic in Australia is about 66. So of those 2 million with type 2 diabetes, half are over 66. And of course, being over 66 brings a lot of challenges in terms of the choice of therapy, the choice of intensity, choice of target, and also what is appropriate in various situations. Next slide, please. So here's Pam. She's 71. She's had diabetes for about 18 months. She had gestational diabetes. She had dyslipidemia and hypertension as well, but she's also prone to dizzy spells and occasionally has bladder problems. Her BMI is 27, but her blood pressure is a little bit high. But her A1C certainly is not good, at 8.2. Maybe her bladder problems are due to high sugars. Maybe they're not. We don't know. Her GFR is 65, which is probably average for a 71-year-old, but it's still not normal. It's certainly reduced. Her dose of metformin, a statin, and a blood pressure lowering agent keeps her under control. Next slide. So of course in Pam, and given her age and her BMI of 27, weight loss is not a priority. Sustainability is not necessarily a priority either, because we're not talking, may not be talking many years. We want control, and we want safe control, and that's the most important priority. We want something that she can take easily, it's easy to comply with, but most of all she'll tolerate and not cause hypoglycemia. So compared to the other cases, how well, panelists, do you think she will be in tolerating an SGLT-2 inhibitor?
I think Pam certainly presents a different picture where just her quality of life is more significant here. So what jumps out at me is her dizzy spells and her bladder problems, and how she's going to manage that with some of the side effects that we have seen possible with SGLT2s. So are her bladder problems going to be increased? Is her dizzy spells going to come worse? And is the thiazide that she's on going to contribute in any way here as well? So definitely a different scenario with Pam.
Yeah, I absolutely agree. It would be interesting to tease out what the cause of her dizziness is. Certainly if she was experiencing postural hypotension, an SGLT2 inhibitor would certainly aggravate that. Increase her risk of falls. She's at risk of an osteoporotic hip fracture, which could be fatal. So we would want to be very, very careful about utilizing an agent that, whilst not causing hypoglycemia, which is certainly an advantage, could be presenting other risks. The compliance will be tied in very much with the tolerability. If she's getting awful bladder symptoms or if her dizziness is worse, then her compliance would certainly suffer as well.
Thanks, Gary. Nicole, next slide, please. So one of the issues that is meant to be mentioned already is the issue of volume depletion. It's very clear when you use an agent such as an SGLT-2 inhibitor, when you pee a little bit more, your intravascular volume goes down. Most patients in the trials don't experience a significant increase in either postural dizziness or hypotension. But notably, all of these trials needed patients with postural hypertension were already excluded. So that's one of the reasons that although the trials say, oh, we don't see much of it, that's because anyone with these kind of issues is not there. And someone with isolated systolic hypertension, stiff arteries and diabetes like her, postural dizziness should be taken as very important. Next slide, please. But the other really important issues are around infections. And of course, she's had bladder problems before, and you start going, well, what is the issue about UTIs? Because of course, if you put glucose in the urine, you increase your risk of UTIs. UTIs is usually a female problem. It's more common, it's about 10 times more common in women than men. And about 3 in every 5 women without diabetes will get a UTI sometime in their life. And 1 in 3 will get a recurrent infection. Uncontrolled diabetes increases that risk somewhere between 2- and 3-fold. And this is primarily mediated by glucose in the urine. So you might think, well, this agent should increase UTIs. But, next slide please. The interesting thing is when you look at the phase 3 trials, again the red bars indicating patients on an SGLT-2 inhibitor, the blue is placebo. In fact, what you see is no increase in UTIs at all, which is a bit odd. One of the reasons, of course, is that anyone with bladder problems was excluded from these trials. But the second reason is kind of interesting, because what happens when you pass more urine is that you empty your bladder more often. And that turns out to be very good for reducing the risk of UTIs. And that's one of the reasons why you don't see an increase in UTIs with this agent. Next slide, please. But what you do see categorically is a marked increased risk of genital infections, particularly and specifically genital candidiasis or thrush. So in these trials, somewhere between 1 in 12 to 1 in 10 women who were treated with this agent developed genital thrush requiring treatment. And that's a very significant burden. Next slide, please. And most of these events occur within the first 3 to 4 months of treatment. They're more common in older individuals than younger ones. They often occur associated in terms of timing in the week before a period. But the symptoms are classical. A sudden onset of itch, sudden quite significant discharge, not much odor, and marked pain, sometimes with redness. This is a very, very common presentation, and almost every woman with diabetes has already had genital candidiasis at some point. It's a very common thing and very easy to detect. Next slide. Next one. The thing about it is that it's also very easy to treat, and that it's treated very simply with, you can buy over-the-counter stuff, either an antifungal cream, suppositories, or an oral azole. Mild infections need a short treatment. Severe infections might need a little bit longer. But the really important thing about this infection is that you need to plan for it. Is that if an SGLT-2 inhibitor is being used by your client, and you're going, you know, what do I need to tell them? You need to get them to know what to look out for, what to expect, not to fear it, not like a hypoglycemia, but to understand that this is a resetting of the flora. And indeed, if the drug works, which it should, and you have candida there to begin with, then it can cause the candida to overgrow and cause an infection. And when you treat it and the candida is eradicated, then it won't come back and you're cured essentially. And if the drug doesn't work and you have a treat with an infection and it doesn't settle, then it wasn't candida in the first place, and then you do need to go and see your doctor. So many doctors and educators just say to patients, be aware of it, be vigilant, and if you get symptoms, don't sit on it for a day or two and wait to see the doctor to do something about it. just go and treat it yourself. It's actually cheaper to do it that way, and it's just as effective to do it that way. But it does take a degree of training and also a degree of, wanting to discuss genital infections with patients with diabetes. It's not an easy thing to talk about. It sounds a bit yucky, but it is critically important because, the most common reason for patients to discontinue this agent in Australia is because they get a genital infection. They don't need to discontinue. They just need to treat and it'll go away. But they're so afraid of this and such a big thing that happens, then they often go, oh, it's all too hard, it's drugs causing it. It is so important to educate to get around this. Next slide, please. There's some suggestion in terms of anecdotal that you can reduce the risk of developing a genital infection by changing genital hygiene. For example, wiping after urinating, using probiotics, other kinds of washing procedures might work, but it's still not clear whether that's the case. Certainly the best solution at the moment is just vigilance and early effective management with over-the-counter therapy as required. Next slide, please.
There are a couple of questions from the audience, if you want to do those with the panellists first, before we move on to case number 3. There's just 2 questions, so thank you to the audience for putting those up in the chat box. The first question for the panel is there a place for SGLT2s in type 1 diabetes?
Let me answer that very briefly. My belief is no. I think that very clearly these agents work in type 1 diabetes in terms of lowering glucose. But as a result of the changes associated with SGLT2 inhibition, they do increase ketogenesis. And if you have a patient, for example, who is reluctant to increase their insulin, taking SGLT2 to lower their glucose, they're going to pull back on their insulin to get better weight loss. Less insulin, more ketogenesis. I can really see a major increased risk of ketoacidosis with this agent, and I don't think it's going to be safe in the kind of patients that you might want to use it in type 1. I think there are better alternatives that are coming through, and I don't think that you would want to use it in any of your type 1s. I don't know how you feel, Gary, but it just scares me, the idea of ketogenesis in a type 1.
Yeah, I think you've summarised it very well. There are some small studies that have shown it to be effective, but whereas most type 2s are going to have some insulin on board, and hence we don't see as much ketosis in type 2s, although it does occur. In type 1s it is a concern, and particularly for those who don't fully understand that they do need insulin. It's not just about controlling the sugars. Insulin does a whole lot of other things as well. So yes, tread with caution.
In fact, it turns out that generating ketones in type 2 diabetes is quite handy because, in fact, that ketogenesis, the kind of ketogenesis that you get with, for example, with the CSIRO diet, is actually good at suppressing appetite. And so some people actually aim for that. And one of the benefits of this agent in type 2s is that it does make your ketones rise a little bit. The problem is that in a situation where you're not missing insulin and you're making ketones, it is a asking for trouble, I'm afraid.
Absolutely.
Thank you.
Second question.
Yeah, and the second question was just about SGLT2s and their PBS. So what's the situation?
Gary, you want to comment?
Yeah, so it is a little bit of a mixed bag. At the moment, dapagliflozin has a streamlined authority as a second-line agent. So essentially sitting parity, if you like, with DPP-4 inhibitors. Canagliflozin is still a phone authority, and that will in fact come off the PBS in August. And this relates not to issues around safety or efficacy, but it's really about wrangling around dollars. Empagliflozin, I think on the 1st of April, will have a similar listing to what dapagliflozin has now. In other words, streamlined authority. DAPA will in fact move ahead to have an additional indication, funded indication. It's had this TGA approval for some time now, but it will now be funded in combination with insulin. So it is a little bit of a mixed bag. I suspect that what will eventually happen is that EMPA will follow, and we'll probably have 2 SGLT2s in the interim that will have a streamlined authority that will be similar access to DPP-4s as second-line agents, and they'll probably both eventually have the indication with insulin. So just a brief summary.
That's a good segue perhaps into this last case where we're looking at the addition to insulin. If you go to the next slide, please. So here's Kevin, he's 50, his blood pressure is high, but his big issue is his BMI. His BMI is 37, and he's failed oral therapy and is now taking 100 units of insulin every day in addition to his metformin. And yet his glucose is not controlled, his A1C is 8.2. Clearly this is the kind of person that we pull our hair out about, and we find ourselves perpetually increasing his insulin, increasing it with very little gain sometimes. And we now have an alternative. Next slide. So the real opportunity now is to add in an SGLT-2 inhibitor. He's got plenty of glucose on board and plenty of kidney function, so that by increasing, by peeing out glucose, not only can you avoid not having to increase his insulin, but actually by reducing the glucose, he can actually restore some of the sensitivity to insulin that he'd lost because of his high glucose levels. So there is a logical synergism between them. And this is where an agent like this really can be very helpful in that, kind of vicious cycle of increasing insulin and worsening glycemic control. And of course, with the hypo risk, you start going, is he really taking the insulin? And suddenly coming in with an agent that works entirely independent to that, entirely independent to the gluconeogenesis, entirely independent to the pancreas, then suddenly you can see quite remarkable reductions in glucose without needing to step up the insulin, and in many cases actually reduce the insulin requirements, which is exactly what he wants for his weight control. So in terms of the panels, I know Gary's very excited about being able to, from the 1st of April, to use dapagliflozin through PBS funding on top of insulin in some of those recalcitrant patients. How about for Kevin?
Look, absolutely, and I think as you alluded to, this gentleman is very insulin resistant, and by reducing his blood glucose, we're going to get rid of some glucotoxicity. So we might see some recovery of endogenous beta cell function. Weight loss will also reduce some of his insulin resistance. We know that in combination with SGLT2s in combination with insulin, SGLT2s are insulin sparing, so we can sometimes see a reduction in insulin use in the face of an improved HbA1c. So no, as you quite rightly said, I think he would be the ideal candidate for this combination. The other thing is, as you pointed out when you were explaining the mode of action, the higher the glucose, the more effective these agents are. And if he's on a basal insulin, we would get this nice complementary effect in terms of the SGLT2 being most efficacious when glucose is highest, and that would be postprandially. So definitely a good combination.
Nicole, what about hypos in this guy when you add an SGLT2? What does an educator need to remind them about?
Exactly. Just, I guess, to pick up with his monitoring, what I was going to say for Kevin, though, he might feel like he's having a win for a change. He might get a bit of weight loss, and he might be able to reduce that dose of insulin. I don't know how many patients think that they're failing when they keep bumping up their insulin dose. But yeah, definitely monitoring is really important here, and looking for signs of hypo and how to treat successfully. So, but I think it would just be a matter of dropping back his insulin dose.
Yeah, it's critical when you have someone on insulin and you are changing their regimen. Every time you change the regimen on someone on insulin, you have to be especially vigilant for hypoglycemia, because sometimes your intervention surprisingly actually works. And when it works, of course, you have to sometimes pull back quite markedly on the amount of insulin that you need. And that just needs be very proactive in terms of warning people and saying, if you're getting signs of hypo, if you're feeling issues when this drug is working, then come and see us or pare back on your insulin. We'll plan to rescale things. But it really takes a degree of education when you initiate a new regimen on top of insulin, be that SGLT-2 or DPP-4 or anything, that you have to be prepared to change quite rapidly, because sometimes it actually works. Okay. So any other further questions? We probably don't need that last slide, which just shows that it does work on top of insulin. I just want to show one more slide. Don't go back one here. This is just an example of what happens when you add it on top of insulin. There's a standard therapy on the top stage where they had insulin and then from 52 weeks up titration. Whereas with the Forxiga, the dapagliflozin, again a reduction, really nice reduction of an A1C of 1% without having to up titrate the insulin, and that's the real advantage of this agent. Okay, any further questions? We'll take any questions at all.
I've just got one through. So, just how much would you suggest to reduce the insulin dose?
It depends on why you're doing it. So in the first instance, what you have is an individual with poor control at 8.2. So you don't want to start pulling back the insulin immediately, because what you find is that now that you're actually getting on target, there's nothing going wrong. You want to stay where you are. And in this trial, actually, when you look down here, they actually in the control group didn't actually reduce the insulin at all, and yet in the placebo group they had continually needed to step up the insulin in terms of units, and so by the end of 2 years they were 19 units different. So in most instances I wouldn't take down the insulin immediately, but I'd just be vigilant, I'd be organized and proactive and say, look, if you notice, if you're monitoring the sugars are going low, or if you're feeling low, let's come in and let's do a discussion about or plan about reducing the dose. But in most instances, their sugar levels are just enormously high anyway, and so you're best not to touch the insulin and let the SGLT-2 do the job when the sugar levels are high, and the basal insulin do the job for the rest of the time.
Did Nicole or Gary want to add anything to that?
No, I think just to really add to what Merlin said, that generally speaking you're going to be adding another agent because you're not achieving your glycemic targets. And in that case, if you simply pull back the one agent, you're probably just treading water. So it's just about where your starting point is, I guess.
I mean, unless the agent isn't working, and a classic example of this would be an individual who has been taking a metformin and sulfonylurea. It initially worked, and now their A1C's drifted up, and so it's not working anymore. In that situation, it's just as easy to stop the sulfonylurea, which isn't working, and replace it with an SGLT-2 or another agent. And in that sort of circumstance, you can get very good responses to an agent that isn't working. But in the situation of this guy on insulin, his insulin is working. It's just that getting rid of insulin is not going to help him at all, and it would end up being counterintuitive. And certainly, if you pull back on one when another one comes in, it's less likely to be effective. And then he'll go, well, that's not fair. This new drug that you gave me doesn't work. You want to make it. You want to maximize the opportunity here. And if the drug suddenly works really well and causes hypo, you could say, by golly, it's a powerful combination. We can pull back on things now. But that's a really positive reinforcement for him to see his sugars going down. So don't touch the insulin.
And just one last question. How long would you leave patients on this agent?
Our experience with this agent, in trials only goes about 4 years. It's really been clinically available only 2. There's no reason that they can't be on this, as long as their diabetes, as long as they're alive. There are human beings out there who are born without SGLT2, not reduced by 30% but 100% down, and they lead normal, healthy lives. So if you're 100% SGLT2 inhibitors your whole life, it's not a problem for you. So I can see no reason in remaining on this continuously, with one exception. If you get good glycemic control and your sugar levels aren't very high, it's not going to cause much glycosuria, so there's not much benefit in that circumstance. So if your patient discovers lifestyle, diet and exercises, it has bariatric surgery, loses 70 kilos, then you don't need to be on medication. And SGLT2 inhibition is completely unnecessary in that circumstance. That miracle happens once in a while, but when it does happen, you can come off therapy almost entirely.
Okay, I think we'll finish it up there. Thank you very much to Professor Merlin Thomas, Dr. Gary Kilov and Nicole Frayne for spending time with us this evening. The webinar has been really great and we've answered everyone's questions. I'd just like to remind you that there will be a webinar survey at the end, and the link to the survey will be also sent to you if you miss it after this webinar. You will get a certificate for attendance.
Come back for our next webinar, which will be focused on DPP4 next time, as opposed to SGLT2 this time.
Absolutely. So the registration for the next two webinars is open, so you can register for our next webinar and the one after that, which will be on DPP4s and GLP-1s. So thank you again, and we will see you next time.
Thank you. Good night.
Good night.